Well, good morning, everyone. Welcome back. Thank you, Ethan, for a great opening talk. Let's wait for a moment for the slides to come up. So this talk, which I alluded to yesterday in some ways, kind of came out of this experience that I had and that Bonnie also shared that she had and some of the other clinicians that have been doing this for a while, where we started our career in cannabis, I should say, mostly just working with THC with our patients. And then after a few years, along came another option to work with CBD, and we could combine that with THC. And then another option came along. We discovered the acidic cannabinoids had value. We kind of added those in, and then CBG came along, and now there's some THCV and CBDV. And I can imagine that for a lot of people just coming into this field, it's a little overwhelming because there's a lot of options, and many of them have overlapping therapeutic effects, therapeutic potential, and you see a certain patient with some symptoms, and you wonder, well, where the heck do I start? And so what I wanted to do with this talk was just bring in some basics from the preclinical and clinical literature to show you what happens when we combine these cannabinoids. I think we all in this room are aware that their combinations are often superior to their isolated usage. But how do we do that? How do we approach it and make sense of it? So, and just for the folks in the back, yesterday I had like a full screen down here. It's not essential, but it's a little easier to see. So in the next 28 minutes, what we'll go through is just a little reminder like yesterday about how complex this is. We'll talk about the major chemotypes, acidic versus decarboxylated, the role of Chemovars, I'll just mention that, and then the types of interactions. And then on the right column here, we're going to go through all of these combinations, some very quickly. What I'm really going to emphasize is the THC plus CBD one, because I think a lot of us bring a limited understanding of what happens when we combine these, and so I want to go into some of those nuances and give a more complete picture of that. So yesterday I talked about this as a multi-compound, multi-targeted medicine that interfaces with the ECS. There's incredible complexity here, and if you have this tendency to want to be reductionistic and to really understand what's happening at what receptors, that might help in some cases, but I think what's more helpful is to kind of zoom out and look at pattern recognition and trends and what we're seeing with our patients and also in the literature. There are 4 main chemotypes of cannabis. This is just the nomenclature. Chemotype 1 is THC dominant. Chemotype 2 has relative balance of THC and CBD. 3 is CBD dominant. 4, CBG dominant. There are some THCV-rich varieties of cannabis. I don't know that we have any that are truly THCV dominant without, with very trace levels of the others yet, but I'm sure that's coming. And so this is what I want to use as a framework for thinking about when a patient comes in to see me, where am I going to start? I'm going to start with typically one of these major chemotypes. And then within each one, there's this question about, is it in the acidic or raw state, or is it decarboxylated, which can be very different in some cases. And then within these chemotypes, of course, there's different chemovars, the different varieties that can have very different properties, very distinct properties. But the way I see that in a lot of cases, most of the time, is like the old-fashioned radio, where you have the big tuning knob to kind of find the station, and then the little tuning knob to do the fine tuning. I consider the chemotypes like the big tuning and the chemovars the finer tuning to really dial it in, to maximize the benefits or minimize the adverse effects. And I'm not going to talk a lot about the chemovars here, even though some of them are very special and there can be highly selective responses. That's also a hard thing to accomplish because the naming is all over the place and the consistency from one batch or one store to the next is problematic. So I encourage you to focus on the chemotypes, especially if you're getting started here and even if you're not. And then the 2 main types of interactions that we might be thinking about here are the pharmacokinetic interactions, which are interactions having to do with absorption, metabolism, excretion, distribution, and the pharmacodynamics having to do with their actual physiologic effects. And so, I'll apologize in advance. It looks like the formatting got a little messed up. I did correct it this morning, but some of the images here are going to have a clear background instead of a white one, and I apologize for that. So here's an example of a PK interaction. This was a really interesting rodent study where they compared blood levels of cannabinoids administered in a full spectrum extract with the same quantities of those cannabinoids but administered alone. And they were given orally to mice in a single dose. And so this is what it looks like. This full spectrum extract, as you can see here, it had a little bit of just about everything. It was around half decarboxylated or somewhere in that range. There was CBD, CBDA, THC, THCA, and CBDV, CBGA. And so they tested those 6 isolated cannabinoids in the same quantity against the full extract. And what they found here's an example with CBD, and this is kind of what you would expect. In the light colored line here, we have the purified CBD, and in the dark we have the same quantity of CBD in the context of the extract. And you see there's much better absorption with the purified CBD. And the typical reason for that is that fat-soluble compounds, when they're taken orally at the same time, they compete with each other for some absorption. You see this with fat-soluble vitamins and other compounds. But what they didn't expect was this. So here we have CBDA getting absorbed much better in the context of the full extract than it did in the isolated form. It was 14 times higher area under the curve. So what the heck was going on there? Why did CBDA get absorbed so much better? And the diligent researchers, this was Jonathan Arnold's group out of Australia, they ended up figuring out that this had to do with an efflux pump in the intestinal border. And so just to orient you, I'll show it on this slide here. We have the lumen of the intestine would be here, and here's the blood supply. And so when the cannabinoids get absorbed, some of them are kicked back into the lumen through this efflux pump. And what the researchers discovered was that low amounts of CBG or THC would inhibit that BRCP efflux pump, prevent the CBDA from getting kicked back out, and therefore increase the absorption of CBDA. Now, this was in rodents. We don't know if this is exactly the case in humans, but we do see very high levels of CBDA bioavailability when taken orally in humans, so there's a high likelihood. So what would be the take-home from this? It might be that if you're using CBDA, it would probably be helpful to have a little THC or a little CBG with it to maximize the potential for absorption. All right, so that's an example of a PK interaction. Now let's move on to the main topic here, which is THC and CBD. And we'll start with kind of where we're all coming from. Here's a study of 177 patients with cancer pain who were on opioids. They were treated either with nabiximols, the THC-CBD combination, or the same dose of THC, or the same basically spray method of THC alone. And they were allowed to titrate up to however many sprays was effective without adverse effects, and then looked at the levels of pain. It turned out that the people who were receiving the THC-CBD combo, they ended up using somewhat more sprays, not a lot, but a little bit more sprays per day on average, and that's likely because it was somewhat better tolerated. But then if you look at the results here, so this first one is a 10% or greater reduction in pain. And there's really no difference in the proportion of people that achieve that between THC or combination THC-CBD. But this is more clinically relevant, 30% reduction in pain or greater. And you can see quite a big difference here. About 40% more of the people in the THC-CBD group achieve that compared to THC alone. And the adverse effects in both groups were similar because they were allowed to titrate in the way that they wanted to. And so the idea here is that THC was causing some side effects that limited the dose, and CBD was probably mitigating that while adding some of its own benefits. And that's kind of what we tend to think about with CBD. Add it to THC, you're going to mitigate the adverse effects, you're going to enhance the benefits. It makes perfect sense. Let's put them together. And I think that a lot of times that's the case. And it's certainly the case with the severe adverse effects. This is showing toxic psychosis threshold in terms of milligrams of THC taken orally. And this is from a paper from Ethan in 2018. And when you look at, just pure THC, around 18 milligrams, that could cause toxic psychosis in some people. Of course, it's a temporary experience. But when it's combined with CBD, you need a much higher dose to achieve that severe adverse side effect. So this is a summary slide I'm going to keep coming back to. Pharmacodynamic interaction is that CBD is a negative allosteric modulator at CB1, and it can dampen the adverse effects, especially the more severe ones. Now, here's a study in fibromyalgia patients who were vaporizing cannabis, either type 1, type 2, or type 3, or placebo, and they were looking at their subjective pain results after vaporization, but also at their blood levels of cannabinoids. And what they found was that CBD inhalation increased the THC plasma concentrations, but diminished the analgesic effects. These authors suggested this was a synergistic pharmacokinetic interaction, meaning the presence of the CBD slowed down the metabolism of THC, allowing for there to be higher levels, but an antagonistic pharmacodynamic interaction. Those higher levels did not result in better pain relief. It actually resulted in less pain relief. And so there were also reductions in spontaneous pain in this study that correlated with the subjective rating of drug high. So what does that mean? That means that to help the pain in these fibromyalgia patients, it seemed like approaching this psychoactive, this THC effect is what was really helping them the most, and CBD diminishes that. So the question is, beyond dampening and adverse effects, can adding CBD to THC dampen the therapeutic effects? And I think in some cases the answer is yes, and then we have this pharmacokinetic interaction where CBD could be increasing THC levels by slowing its metabolism. Now here's another study, and I apologize again for the slides, THC versus a ratio of 1 to 3 THC CBD vaporized in adults and in adolescents, looking at their subjective experiences after doing this. And this would correspond to about a quarter of a typical joint, the dose of THC that they were getting, 8 milligrams. And what they found was that the combination of THC and CBD at this 1 to 3 ratio was no less psychoactive than the equivalent dose of THC. CBD augmented THC levels again, so it's that pharmacokinetic interaction slowing the breakdown of THC. But despite higher plasma levels of THC in that combination treatment, the stronger effects were not observed, likely again due to that pharmacodynamic antagonism. So the group that received the combination had higher levels of THC, but did not have more psychoactive effects. And then here's a study that was a double-blind randomized controlled trial with 26 healthy cannabis users that were vaporizing either THC, combination THC, CBD, or CBD or placebo, again, and looking at their driving performance in a simulation. And what they found was that the group that had THC dominant only, no CBD, this is their standard deviation of lane position, basically how much are they swerving back and forth. And that deviation was 2.33 centimeters on average. The combination of THC and CBD actually had a stronger deviation, and the CBD dominant vapor didn't change it at all. But what's interesting is the cutoff here, 2.4 centimeters is considered typical of a 0.05% blood alcohol concentration and is thought to indicate clinically relevant driving impairment. So in this case, the same dose of THC administered with CBD was more impairing, slightly more impairing than THC alone. Now, what's going on there? Well, first of all, that was just at the 40 to 100 minutes test. There was no change later on at 240 to 300 in any group. The drivers who consumed THC were generally more aware that their driving was impaired, but the group that received both had less anxiety. They also rated the drug effect as lower, and they had higher ratings of confidence to drive than THC alone. So these findings challenge the myth that CBD can ameliorate the psychoactive effects of THC. What seems to be happening here is that CBD mitigated the THC-induced anxiety, which it tends to do. But maybe a little THC-induced anxiety is a good thing if you're about to get behind the wheel. And so beyond decreasing the adverse effects and decreasing the therapeutic effects, could the combination of THC and CBD decrease the awareness of the impairment or decrease the anxiety related to impairment and therefore increase the risk? I think this study suggests that that's possible. And it's probably not in everyone, but there might be some settings and some patients where that's going to happen. Now, this is a strange study because it involved a very high dosable THC and CBD taken orally in a brownie along with a whole cocktail of other CYP drugs. I'm not going to spend a lot of time on it, but the brownie either had 20 milligrams of THC or 20 milligrams of THC and 640 milligrams of CBD. So this was a 1:32 ratio of THC to CBD, pretty strong brownies. But the people who received the combination with this high dose of THC were more impaired, and they rated the experience as less pleasant than the people who received the 20 milligrams of THC alone. Now, a lot of you are probably surprised by this. You're thinking, well, if I overdose on THC, but I'm taking it with this massive dose of CBD, isn't that going to dampen down the activity at the CB1 receptor and protect me from feeling too stoned? Well, in this case, which was an unusual study, it didn't. And what's hard to see on these line graphs here is that the plasma levels of THC and of 11-hydroxy-THC were much higher in the group that had the brownie with the CBD in it compared to the THC brownie alone. So there is significant pharmacokinetic synergism happening here, increasing the levels of THC and 11-hydroxy, which are both psychoactive. So the question is there a pharmacokinetic potential to increase impairment at high doses when CBD and THC are taken together? And I think the answer is yes. Now here's an interesting study on some young people with epilepsy treated in the UK, and they had a variety of treatments that they could start with. There was the CBD broad spectrum, the CBD isolate, and the CBD, we could call it full spectrum. In the study, they called it broad spectrum plus THC. But those were the options for treatment. And I think if you can see this and follow it along, only 4 of the 35 patients ended up starting off with this broad spectrum plus THC. Pretty much everyone started with either CBD isolate or CBD broad spectrum. But when it didn't work, they would move on to a different treatment. And this is where they ended up down here. And so just to summarize these results on the next slide, in total of the 17 who tried THC, 16 responded, and 13 of them tried CBD dominant no THC first. And then of everyone that responded to the THC treatment, all of them were also taking very high doses of CBD at the same time. Was this necessary? Was this needed? Maybe in some it was and some it wasn't, but kind of a waste of time for many of them, starting with this CBD isolate and CBD broad spectrum with 0 THC. And so I bring that up because in this situation, what I'm suggesting is that low-dose THC, in many cases, can add benefit to high-dose CBD. And if you get a partial response with high-dose CBD, switching over to a full-spectrum extract might be helpful. So that's all I've got for this, and we'll summarize it again later. But this is, I hope that I've broadened your mind a little bit about some of the potentials for THC and CBD to interact with each other pharmacodynamically and pharmacokinetically when taken via inhalation and when taken orally. Let's move on to THCA. This is pharmacologically distinct from THC. It is not psychoactive. It has a lot of beneficial properties: anti-inflammatory, neuroprotective, hepatoprotective, antiemetic, very, very strong antiemetic. A lot of people don't think about that with THCA. Many other targets. And THCA is different than THC, especially because it doesn't act upon the CB1 receptor, at least not as a partial agonist like THC does. And so how do these two go together? Well, they have similar metabolism. And so even though this hasn't been shown that I'm aware of in humans, there's likely going to be pharmacokinetic agonism there. If you take THCA with THC, it's likely to slow the breakdown and could potentiate the THC pharmacokinetically. There was also one study in rodents that showed that THCA was acting as a CB1 positive allosteric modulator. Now, this is exciting because this would be, if this is the case, a positive allosteric modulator at CB1 has great therapeutic potential. When we take THC as a CB1 agonist, we are globally affecting our endocannabinoid system, which can be a good thing, but I think affecting our endocannabinoid system with greater precision, the precision involved with our endocannabinoid synthesis, would be, in many cases, even better. So imagine if we could use something like THCA to selectively enhance CB1 signaling where it's happening, when and where it's happening in the body, based on the wisdom and precision of our own endocannabinoid system. And there's been a lot of pharmaceutical exploration looking for a good positive allosteric modulator for this reason. Now, cannabis tea is a great delivery method for THCA, especially because the solubility of THCA is much greater in water. Especially if you're not adding anything like cream to the water, you're going to have at most a 1:5 ratio of THC to THCA. So you get a lot more THCA when you make cannabis tea. Now let's switch gears to CBD plus CBDA. While THC and THCA are quite different, CBD and CBDA are very similar. They have many similar targets in the body, but one of the main differences is at the CB1 receptor. So all that I showed you about CBD interacting with THC pharmacodynamically, dampening those effects through negative allosteric modulation, this is not likely to happen with CBDA. CBDA is also more bioavailable, but CBD has greater ability to cross the blood-brain barrier. And so what are the take-homes from this? CBDA is also much more potent than CBD, at least in many animal models, like 10x the potency of CBD in a rodent model of Dravet syndrome, even though it barely crosses the blood-brain barrier. 100x the potency of CBD in a model of hyperalgesia, and 10,000 times the potency of CBD in a rodent model of nausea vomiting. So CBDA can be more bioavailable and more potent. These rodent studies don't rely on oral absorption, they're intraperitoneal injection. And then it really makes some sense to combine CBDA with THC, especially in people that do well with THC and that don't want the potential of dampening the the therapeutic effects of the THC, right? We're avoiding that negative allosteric modulation. So CBDA and THC go really well together, as demonstrated in this model of inflammatory pain, where the tiniest doses, I'm not going to get into it, that was my lecture last year, but if you see this study, you wouldn't believe how low the doses were that were effective when combining CBDA and THC for inflammatory pain. Now, moving on to CBG. CBG has many mechanisms of action, but one of them that I think is worth bringing up in this lecture is its activity at the 5-HT1A serotonin receptor. This serotonin receptor is thought to be the target of CBD and CBDA in its anti-anxiety and anti-nausea effects. CBG has been shown to be a neutral antagonist at this receptor and could potentially oppose some of the effects of CBD. At least in one animal study, it was shown to oppose the antiemetic effects of CBD. And it could be unpredictable when combined with other serotonergic agents. I haven't seen a lot of this, but it's a caution. Maybe I've seen a couple cases now where CBG seems to have altered the effects of CBD, but it's something just to watch for if you're using them together. I think in most cases they go really well together. And remember, this is just one of their targets, one of many. For example, CBG is also a PPAR gamma agonist with stronger affinity than THC or CBD. And in vivo, this was shown in animals where CBG could enhance, or the effects of CBG on this receptor were enhanced by CBD. So I think combining these two, there's some potential for antagonism, there's some potential for synergism. And then moving on to THCV, this is a CB1 antagonist at low doses, a CB1 agonist at higher doses. It's probably most well known for producing weight loss and decreasing body fat. It also has anticonvulsant properties, and it lacks the adverse effects of inverse agonists like rimonabant. So rimonabant is a CB1 blocker, the anti-munchie drug that was marketed in Europe and almost here in the US, but it makes people really upset and suicidal. Not a good idea to block CB1 in humans. THCV can gently block CB1 and get some of those same metabolic benefits without causing those types of adverse effects. Actually, it can be experienced as quite uplifting. But that's usually, even when administered as an isolate. And so this was a study that looked at a very low dose of THCV in humans, 5 milligrams taken orally twice daily for 13 weeks. It decreased fasting glucose. It increased adiponectin. It improved beta cell function. There were mild to moderate adverse effects, but when the THCV was combined with CBD, those metabolic benefits vanished, even when it was combined with a low dose of CBD. They tested it both against 5 milligrams of CBD and 100 milligrams of CBD, and those metabolic benefits vanished. So very interesting that CBD may attenuate or remove some of the benefits of THCV. So let's review all of this and then we'll do a quick case. THC and CBG may enhance the absorption of CBDA via the intestinal efflux pump. CBD and THC have pharmacokinetic agonism and pharmacodynamic antagonism. Sometimes that antagonism is good because it's blocking the side effects. Sometimes it might not be good because it's blocking the therapeutic effects. And there are complex cognitive and subjective effects, including more confidence driving in that one study. CBDA and CBD are similar and likely have pharmacokinetic agonism and different potency and brain penetration. THCA and THC are distinct in their activity. They likely synergize pharmacokinetically. THCA may be a positive allosteric modulator at CB1, which could enhance endocannabinoid function and enhance the activity of THC. CBDA and THC may have some synergistic effects together in inflammatory pain with ultra-low oral doses, and in general seems to be a good combination for my patients. CBG can act synergistically with CBD via PPAR gamma, may block some of the serotonergic effects, and CBG cannot replace THC or CBD, but it adds distinct effects. So I know that when you're thinking, what should I do, switch or add, I think that sometimes the combination of all of them can be useful, but we wouldn't start there. CBD can block the metabolic benefits of THCV. So my recommendations, when you're approaching a patient and you're thinking, where do I start? Work with full spectrum chemotype categories. Think to yourself, am I going to start with 1, 2, 3, or 4? What am I coming out of the gates with? Try one at a time, explore dose response effects, and then add or switch. So you have kind of a starting dose, you have a dose that you're going to titrate up to if there's no adverse effects. You're going to see how they do within that range. As Bonnie says, you're kind of ruling it in or ruling it out. Is this chemotype going to be effective? And then depending on how far you get, you can switch to something else or you can layer something else on top. I still think that the combination of THC and CBD, this type 2, is a great place to start. It's very effective. But if you're relying on it to produce decreased psychoactivity, that may not be the outcome that you see in everyone. It's certainly going to be that way in some people. Include at least a little THCA with your THC. Trust me, don't fully decarb your THC. It's going to work better if you don't. The possible exception to that is in people that need THC but are ultra sensitive to it, and you want to have a more precise low dose. Include at least a little CBDA with your CBD. They work similarly, and the CBDA is much stronger. Include at least a little THC or CBG with your CBDA to enhance its absorption. Observe closely when you're adding CBG to CBD. You might not get what you expect. And avoid CBD with THCV if you're looking for the metabolic benefits. So these are some general recommendations, things to look for. And I'll give a quick case in the last minute here. So autism spectrum disorder, age 5, came in with nighttime awakenings, intermittent aggression, and hand biting. So I started him on a balanced ratio. The products that we work with, that I get the great pleasure of working with, I've designed and Healer makes. So this is our 1-to-1, but it's actually a 1-to-1-to-1-to-1. It's half decarboxylated. 1 drop is 1 milligram. And so he started off with 5 drops in the morning, so a little more than 1 milligram of each of those. And then I chose a formula called Healer Pain at night, which was a THC to THCA 1-to-1 formula for bedtime. And the reason I chose that was really because I wanted to incrementally adjust in half milligrams instead of full milligrams of THC. And so came back 1 month later, global improvement in all areas. He's at peace. The medicine has been a game changer. I'm in absolute awe of how it has changed his life. He's even willing to try more foods. He had titrated up to 15 drops of balance in the morning, so almost 4 milligrams of THC in that dose, 10 drops in the afternoon, 2.5 milligrams. Pain was 4 drops before bed, so 2 milligrams before bed. But 4 months later, he had started public school and his symptoms worsened. They had titrated up on the balance formula, so we were still exploring the dose-response curve. We went up on the balance and the pain. Symptoms improved some, but he was still pushing his peers, attempting to bite others, slapping himself in the face, waking up at 3 or 4 in the morning, and he was still making developmental progress. So we changed the nighttime formula to our more sedating THC-dominant Healer Night, and then we started adding our CBG formula during the day. He started sleeping through the night, squeezing or giving a little pinch instead of being more aggressive. It was stable at 25 and 20 drops of balance in the morning and the night. Again, that's around almost 6 milligrams of THC in the morning and 5 not in the night, but in the afternoon. CBG 10 milligrams twice daily, night 6 milligrams before bed, and the efficacy was maintained for the following 6 months. So I think that shows you a case where here's what I decided to start with. Balance during the day, THC dominant at night. Symptoms returned, I titrated up. We didn't get the results we were looking for. We layered in CBG, that was my next choice, and we got the symptoms under control. And that is all I have for you today. Thank you so much.